Good afternoon. My name is Peyton Miller. I've been a paramedic for 8 years. In that time, I have worked in both training and operational capacities, and now it is my pleasure to represent the Grady County EMS at this meeting to discuss the possible implementation of a MIH/community paramedicine program. Over the course of this presentation, please note that those two terms, MIH, meaning Mobile Integrated Health, and community paramedicine, will be used interchangeably. So the purpose of this program is to upfront serve our community. Grady County has a higher poverty rate than the rest of the state, with our poverty rate being 20.6%, whereas the state average is 13.6%. This population living below the poverty line can lead to a lack of sufficient health insurance. It could even lead to a lack of any health insurance, which would decrease the amount of visits to primary care, as they cannot afford the actual visit themselves, or they cannot afford the copay if they're underinsured. Also, the underinsured or non-insured population have major concerns with obtaining medications. Some of these medications can be hundreds of dollars. Some of these medications can be next to nothing. It largely depends on what the medication is, has a patent expired on it, and different factors like that. But these patients that are lacking the ability to gain access to their primary care provider are our target demographic for this. The MIH team is set up to improve the outcome of non-preventable emergency calls by reducing the calls for things that could have been prevented if we had been there sooner, or if we had been there ahead of time. These type of calls that are non-preventable include, but are not limited to, cardiac arrest, stroke, car accidents, assault and battery, anything like that. We can't control that, but we can control whether or not our patients are taking their medications, whether or not the patient's house is clear of obstructions and a safe place for especially our elderly population to ambulate around or walk around. This program will start with targeting the falls, only because that is a major call type that this county responds to, and it is also one of the cheapest that we can design a system for. However, the course of this presentation will also discuss the implementation of expanding MIH into the chronic health management and lowering hospital readmissions rate. One in 4 patients, adults, will sustain a fall this year. That is according to the CDC. In Grady County, 18% of our population are over the age of 65. On that same token, from the CDC, the leading cause of traumatic death for all patients over the age of 65 remains falls. Now, let's talk about how this is directly going to impact us. Grady County has been level 0 23 times already this year. That is from January 1st, 2025 to July 1st, 2025. The average time that we stayed level 0 was 48 minutes. That is an average of 48 minutes that this county did not have any available emergency medical response in its borders. The maximum min for those, the shortest we've ever had that we were level 0 was 12 minutes. And the average was 1.8 hours, which is about an hour and 48 minutes. These delays that we spent and times we spent at level 0 caused an average time for call delay of 37 minutes with a maximum time of 56 minutes and a minimum time of 6 minutes. Please note that this data and those maximum mins do not include mutual aid responses, and we did have an over 60% grant approval rate when we requested mutual aid. However, it is important to note that we cannot always rely on mutual aid. An incident that comes specifically to mind is a cardiac arrest that originally came out as a ultra mental status. We did dispatch the fire department, which is our protocol. Fire department got there, found the patient to be conscious but very disoriented. In that same time, they took vital signs. They found the patient to be extremely hypertensive, which means their blood pressure was exceptionally high. But over the course of the 39-minute delay, which was just over the average delay for when we're level 0, the patient went unresponsive and became pulseless and apneic. The fire department did begin CPR. By the time EMS got there, the patient was still pulseless, the patient was still apneic. They had no electrical activity of their heart. They were in what we call a systole. The EMS crew did attempt resuscitation, but it was unsuccessful. I do not have a crystal ball. I do not know if an EMS unit being there sooner could have changed that outcome. However, I would much rather err with the belief that we cannot allow that to happen again than to say, oh, there's nothing we can do, when there is something we can do. So the goals of this program, to improve our response times. Secondly, we want to reduce the non-emergency ER visits. As of 15 minutes ago, before coming into this meeting, when I spoke to Archbold, they were on diversion. They had been on diversion for 3 hours. For patients in their lobby, the average wait time is over 5 hours. Charge nurse said she had somebody who's been waiting for over 8 hours. These hospitals are at maximum capacity and they cannot handle the influx. By removing these non-emergency visits, these patients that are coming in because they need their blood pressure medication, these patients that are coming in because their blood sugar was low, maybe it was treated by EMS, but our protocols dictate we have to take them to the hospital for follow-up care. All these things are really non-emergency, and they need to be redirected by other means. Then we want to enhance the patient care for our community. We want everyone to leave their experience with this county's EMS agency knowing that they have gotten the best care possible. I want them to have interaction with my coworkers and think they are awesome and that they truly care about them, because we do. This MIH, or Community Paramedic Program, will allow us more face time with these extremely vulnerable populations. That this program will allow us to coordinate with pharmacies and primary care providers to obtain some blood pressure medicines for these patients. As it grows, possibly even in conjunction with the pharmacy, being able to have small quantities of these routine and primary care medications that can be issued out to these patients, not to change their medication, but if they're out of their metoprolol, maybe we can give them 3 or 4 days to get them through the weekend so they can get to the pharmacy on Monday. Or if this program changes its focus and we develop it more into a expansive discharge model, which is what we'll get to a little bit later on in this presentation. We even coordinate with Archbold to possibly pick up their medication for them if they have not done so already, or have their medication delivered to our station at the start of that shift if the patient hasn't picked it up already. So the objective is to obviously get this program off the ground. We want to start this program, and we want to start it sooner rather than later. In order for that to happen, we need to have 4 trained EMS personnel, community paramedics, 2 of which will be full-time, 2 of which will be alternates for call-outs or vacation days. Additionally, we want to reduce that level 0 status. I've said by 40%, but if we can get it lower, that's even better. So what will we need? We will need an SUV or a hatchback style vehicle. Currently, the Sheriff's Office has 8 of them on sale, or they're planning on selling back for $11,000 a piece. I have preliminarily talked to the Chief Deputy, who said he would be interested or entertain the idea of allowing EMS to purchase that from them or transferring it to EMS based on the county board's decision. We'll also need an AED. The program will start off with an AED, as it will not initially cover extensive medical exams. However, as the program evolves, it will need to potentially add in another cardiac monitor. Initially, an AED is $800, as opposed to a cardiac monitor is going to be closer to around $12,000 to $15,000, depending on your brand and specifications for the model. So we'll need 1 new mounted radio to go into the car, and then we'll also need 2 portable radios. The reason we are requesting 2 portable radios and not just 1 portable radio is at this time we currently issue all full-time personnel a radio. We do this so in the event of a mass casualty or in the event of a recall of personnel, we know that we will have enough radios to go around. So that is why we requested 2 portable radios. And then we'll need a tablet with a high quality microphone and a high quality camera, because even in the beginning stages when we're talking about fall risk reduction, we still need to have some way of communicating via telehealth network in the event we find ourselves in a situation where we need more extensive care than what can be provided by us. This would also potentially allow for this unit to immediately respond to low acuity calls in the event of a level 0, low acuity 911 calls in the event of a level 0, and treat and release that patient before returning to their normal duties of inspections. So personnel, like I said, we'll need 4 community paramedics. We need to update some training for our dispatchers. The dispatchers, that is not an initial phase, but if as the program develops and it becomes more established, one avenue of exploration could potentially be to integrate these mobile health teams on a 24-hour basis to where they will be dispatched on the lower acuity calls outright. That is a model that is very common in some of your European countries. England has it. Australia is currently using it. but that is a model that we could look at in the future. That is not an initial requirement for this particular program. And then we need a coordinator. We need somebody to head up the program that can supervise and set up the schedule. The operational aspects of it with equipment and payroll will obviously fall under the current director, but a liaison with the hospitals, somebody that can be the point of contact. I would recommend it be either an internal promotion for somebody in the department already, or assigned to one of the community paramedics when they are hired. Additional agencies. So like I discussed earlier, we will need to establish a rapport and connection with a primary care provider. This can be any of them in town. It could be a PA, nurse practitioner, MD. But having that rapport and having that connection with somebody that is willing to do telehealth and to take those calls from the paramedic in the event that it's needed. Again, at first, those calls will be few and far between, but having that necessary connection is important, especially as we develop this program. We'll also need to get in contact with the Archbold hospitals or AMH, all their different campuses and all their different administrators. We will need their data. We will need their hospital admissions data. We will need their discharge data, and preferably some referral data, so they can tell us, hey, we want you to go look at these patients. This is what they were treated for. This was their diagnosis. This is how we treated them. And by having that treatment and diagnosis in hand, the community paramedic has a much greater understanding of how they can go in, how they can prevent potentially, like we said at the beginning, these falls of and then possibly some medication compliance. DPH. Department of Health does a wonderful job of collecting survey data. The survey data and this population-specific data can be fine-tuned with the help of the hospital and the help of EMS if we work with the Department of Health. Program structure. So we will do a initial mix of post-discharged and personalized in-home care. That is how the CDC classified them in their 2024 article. The reason we have selected this is, again, we're focusing predominantly on fall at the beginning, which is that personalized in-home care. That's going in, clearing obstructions, working with churches to possibly get ramps built, different aspects like that. But it's also going to have some post-discharge care, because if the hospital sees that, hey, this person's a routine problem for falls, or as we grow, chronic medical conditions, then they will refer them to us for that follow-up. Initial operation, I propose that we run it Monday through Saturday, 7 a.m. to 7 p.m. with 12-hour shifts. Like I said, if we expand that later into the future to do a more 911 model, then we could potentially go to 24-hour coverage and involve a more active treatment plan similar to that of what the United Kingdom and Australia are doing. And then that telemed. Currently, Grady County has a primary care provider, both physician and mid-levels, and both have expressed interest in potentially using this program with telemedicine. Now let's get the money. I know, everything comes down to the almighty dollar. So initially, the startup cost can range between $150,000 and $300,000. I put $300,000 on this page because that is the maximum. And the reason I put that there is, after hearing this and as we develop this program, it may be advantageous for us to tailor this program to go ahead and start with a discharge model as well as the personalized in-home care model. And if we start with that, if we started off with a discharge model combined with that personal home model, we will look at that closer to that $300,000 number. If we started at the lower, just individual care, we'll be looking at closer to about $150,000. Again, depending upon exactly the scope of this procedure. With an annual operating cost starting at $200,000 and going up from there as we scale it. Now, the reason talk about upfront costs varying so much, as we develop this program, and if we get into the funding types listed below, hospitals do not want readmissions within 30 days. It counts against them. If Archbold is willing to work with us, similar to that of Phoebe working with Dougherty County, then we would be able to split the cost, and these numbers can change dramatically. So I would just like to be upfront with that. Now, funding types, we have the rural health grant. Both federal and state governments offer different grants for MIH through their rural health programs. Hospital cooperation, and that is a major one. These programs can potentially save hospitals hundreds of thousands, if not millions of dollars, depending upon the number of patients and how effective the program is. County budgets. The county budget would ultimately, at minimum, have to cover payroll and benefits for the staff. They are county employees. We can subsidize and earn some money similar to the way EMS is doing for the county now, but on the front end, the county would be responsible for at least the payroll and the benefits. And then insurance billing. Insurance billing is a little tricky, again, depending on the model you use. If you're using telehealth, then we can bill. If you're doing certain procedures, then we can bill. I have worked with our current billing company, and they said they will help coordinate a fee schedule and get everything set up and maintain us at our 7.5% fee of what they collect. Training and development. Advanced medical life support is not currently required for traditional EMS providers. However, starting in January of next year, it will be. However, not listed on this slide. We would also need to add in GEMS, which is Geriatric Emergency Medical Training. It's through the NAEMT, or the National Association of Emergency Medical Technicians. And what that class does is it's bringing awareness to how the geriatric population interacts with the world. If you're going and you're supposed to be helping these geriatric patients, you need to know how they experience the world. And then also we would put them through a community paramedic program. There's several online options that range in price, but then ultimately they will have to take the international IBIC, the International Board of Specialist Certifications exam for community paramedicine, and that is for credentialing purposes. We do not want to be sending these men and women into this environment without proper credentialing. We do not want to open up them or the county or any other agency to any potential hazards. We want to have our training under wraps and with a bow around it. This training will be conducted over 3 months from the date of hire. Currently, I am a board certified community paramedic, and I will be doing the initial training hands-on portion while they're doing the online portions. The training will be done in 3 months. They will then be given 30 days to test for the international board, depending on availability. That can be a difficult test to get registered for. So if they're trying to register and they cannot register because of the international board giving them issues, we will not hold that against them. And then ongoing education will follow the current EMS department standards, as well as the new standard that will be implemented for our paramedics that will incorporate some of this community paramedicine MIH training. Program evaluations. The current method recommended is the mixed method. We want some qualitative data, we want some quantitative data. Hospitals and grants want to see that their money is doing what we tell them that we say that it's doing. This is done by showing patient contact log, by showing electronic health records. This is done by showing CAD data. We need to have that, and this then following up with hospitals after 30 days to see if the patient's been readmitted. They want that empirical data. However, qualitative data can be just as important when we're talking about getting community support. Without the community support, this program will not succeed. They will not utilize this program in the way it needs to be utilized, and they will resist people coming into their home and trying to help. The old saying that nobody cares what you know until they know that you care, that's doubly true for this situation. We are coming into these people's home and we're trying to help, and they need to know that we're doing it from a good place. So we're going to get that information back from contact surveys. Every time one of our medics has patient contact, that patient will be given a paper survey. They'll be given access to an online survey, whichever method is more convenient and more comfortable for them. Tools. Like I said, the patient satisfaction survey will be done through SurveyMonkey. The provider will also be given printouts of it to hand out to patients that do not want to use online platforms. Incident response logs, CAD details. TraumaSoft has one of the best platforms for this to allow for better data collection as well as better data tracking. TraumaSoft is a little bit more expensive than our current systems. However, it is able to generate data and fine-tune that data better than most other systems. And then all parties will meet at a minimum twice a year. They can meet more if requested, but these meetings will be to review the data, make sure we're taking this program in the way it needs to go, make sure this program is growing the way we want it to, and then possibly expanding the program if the program is doing well. I apologize for the technical difficulties. Apologize for technical difficulties. Not exactly sure what happened. Evaluation markers. So we want our response times to be under 10 minutes. This is from the time the call is received. Dispatch does a phenomenal job of getting these calls dispatched in under 2 minutes. And the average time for travel is usually around 5 to 6 minutes for most of these calls. However, it's important to note that we do have some outlying markers that will lower that will increase that number, such as when we go to Wickham or when we go far out in the county. We want to see a 30% reduction in the non-emergency ER usage. A lot of this is going to be up to the hospitals to report to us and how the hospital documents it, because documentation is everything when we're talking about data collection. Patient satisfaction, I want 85%. 85% or greater. And then monthly data tracking with the help of DPH as well as AMH. These data trackings will be conducted with the liaison appointed by this department and then the liaisons appointed by each of the other facilities. We want to make our EMS response better, and we want to make it faster. We want to build on the existing trust our community has in us to make this program effective. We should expect that the burden on this EMS system and the ERs to be reduced. Hopefully we're taking away some of these lower acuity or some of these quote unquote frequent flyers out of the matrix. We want to get them where they're able to manage better at the house. And then a better understanding of the efficacy and effectiveness of this program for long-term implementation and expansion. So kind of sum everything up, we have a deficiency in this county with EMS. We do not have enough resources to cover it. Hospitals do not have enough resources to cover it, and it's causing a public health issue. We must have a vast support system from our community, coming from the Board of Commissioners today, the administrators at AMH, the Department of Health, churches, community organizations, different groups like that have to be involved. And we want to maintain this measure of flexibility as this program grows. This program is in its infancy. It is so very important that it grows and molds to exactly what this county needs. And as this county changes, it molds into what it needs in the future. Moving into the future, I want to start this program by the end of January of next year. That's an ambitious goal, but I think it's an attainable goal. We have a lot of infrastructure already available in this county. If we utilize it effectively and judiciously, it can happen. If approved today in this hearing, we will begin Q&As and town hall meetings immediately. We want to raise awareness about this program. We want to get the community excited about it and looking forward to it launching, because we want them to know the good that it's going to do for them. Working with, obviously, the county finance office to help write grants. I will be the first one to tell you, grant writing is not my strong suit. But we have some wonderful people in our county finance office that do know how to write grants. They do it every day for the transportation department. They do it every day for law enforcement. They do it every day for us on the traditional EMS side. We want to use them. We want to work with the AMH administrators to determine how this program can help them. If we want AMH to be a participant in this program, they got to get something out of it. So we'll work with them to coordinate that. We'll work with our collections department to set up a fee for service schedule. How much we charge them? How much are we going to try to collect? How much can we reasonably collect? How much does insurance say we can bill? All that needs to be determined very quickly upon starting this program, and once we have a rough outline of how this program will progress. And then work with the Georgia Health Department to obtain any additional licenses and or inspections. I know earlier in this presentation I mentioned possibly using this community paramedic to respond when level 0. If we do that, we will have to get that vehicle registered with the Georgia Department of Health Office of EMS and Trauma as a first responder vehicle. It's not hard to do. It's an inspection conducted by Daniel Warren and a little bit of paperwork. But we have to be able to work with the health department to make sure all of our ducks are in a row on day 1. So, just kind of in conclusion, the community paramedicine program can do a lot of good for our community. It can do a lot of good in other communities. It has been successful in Coppola County. That's right next door. It has been successful in Daugherty County. Again, that's right next door. It has also been successful across many counties and across the country. The data supports it. The finances show that it reduces costs long term. The data shows that it improves quality of life. The data shows that we can make a meaningful impact in these patients' lives. Once again, I would like to thank you for listening to me today, giving me time to address this committee. And if there's any additional questions, I will be happy to take them at this time.